And our next case study is going to be presented by Dorcas Kamuya from Kenya, and it's going to tell us about the Kilifi experience and P. falciparum challenge.
Thank you. Morning. I'm based at the Kemri Welcome to Us Research Program in Kenya. And what I'm presenting is a small descriptive study that we were exploring participants' motivation for participating in malaria challenge study. So kind of linking to the last question that was raised, but in a very different context here. This work was done by a group of us, social scientists. Maureen Jue, who is not here, should have really wanted to be here. But it was also nested within the challenge study, and there was a scientific team that gave us really the freedom to be able to do this work. So I really acknowledge that. We've already had a lot of introduction about challenge studies, so I'm not going to end details about this. But I think what I want to draw out, especially for us to understand, is the intentional infection of healthy volunteers with the pathogens. And this could be done either by exposing them to, in our case, because it was malaria, it was either it could be exposed by being bitten by infected mosquito or by injection of the pathogen. I think that's what I wanted to highlight. There are obviously numerous ethical issues with challenge studies. We've already started hearing some of them. And the most immediate one is that really for the people volunteering, there's no immediate benefit for them. They are volunteering to study, but it's not like other studies where probably they might get some treatment for some conditions, so there's a direct benefit. In this case, there isn't. Often it might inquire, and especially in our kind of settings, long inpatient stay, that is obviously different from your setting where they didn't have to stay inpatient. And there are many reasons why they have to stay inpatient. One of it is obviously to be able to access them easily, because they might be coming from different parts, and also the healthcare systems that are in existence might not necessarily support the kind of care that they require while they are participating. And therefore, this often requires, there's also potential actually to not be involved in economic activities that would ideally have been giving them an income, and we need to take that into consideration. And there's potential to attract those who are economically underprivileged, because obviously there is some level of compensation that goes with their participation. Because of that, there is potential probably to discriminate against others. If those who are turning up to be screened and recruited are the ones who are not, may not be completely representative of the population. So research has been aware of that potential. And of course, anti-inducement has come up quite a number of times whenever we think about compensation levels. And of course, we know we do have limited data about how this really plays out in developing country settings. So the current challenge study at the program is not the first one. We've had a challenge study that was conducted in Nairobi, which was involving healthy volunteers. And the lessons that we learned from that initial challenge study that was done way back in 2010, the paper is one of the references that were given for reading, informed the current setup of the current now challenge study. And the aim is to assess immunity to Plasmodium falciparum using sporozoites. And these are administered through direct venous injection or inoculation. And the current study aims to recruit around 200 participants, but these are divided into 3 cohorts. We had the first cohort that participated late last year, the second cohort that participated mid this year, and that is a cohort where we nested the social science study. And there's a third cohort that was ideally supposed to have already been ongoing, but because of different elections and stuff, it has been postponed to January or early next year. So the study is still ongoing. And what is happening is at every cohort, there are lessons that have been learned and then incorporated into the subsequent one. Now, in the second cohort, they screened around 114 people, and they enrolled 64 of them. And these participants were in residence in a hostel, not in a hospital. There was a very long discussions about where they should be in residence. If they were to be put up in a hospital, there were real concerns that people would think they are seriously sick. They have been admitted because they are sick. And in order not to arise those fears and concerns in the community, was agreed that they will be put up in a university hostel. And this was for a range of between 15 and 24 days. And the residence was determined up to, if they did become infected with malaria after challenge, then they would be treated at that point. After the treatment, there's a regime for treatment of malaria. Then after it is cleared, then they could be let go off. So they didn't have to stay the whole period. It's up to the point that they had become infected. Even by 18 days they had not been infected, they will all be treated for malaria anyway, and then go home. And so there was a lot of discussions about what we needed to compensate. Obviously, fair refunds for all visits were reimbursed, but also the time that it took for them to stay in residence, which was at a rate of around $20 per overnight stay. And this was as per our current institutional policies around reimbursement for time. We had intensive engagement with all key stakeholders, including community leaders, and obviously the participants themselves and their families, about the study itself, but also the consent process itself was quite multi-staged. So there was a lot of discussion about what does it mean to be involved in this study, all those discussions. And so the social science study was really, I mean, my colleague Maureen, whom I've talked about, really did most of the work with the social science study. I was supervising her and advising her, and now she's off doing her PhD, which is fantastic, but also she couldn't make it for today. And we aimed to explore the participants' experiences, perceptions of challenge study, but also what they understood the challenge studies, what they understood their participation was about, and the motivation for participating in those studies. And we did this by, as I said, it was very much nested. So throughout, we made sure that our team was very much working together with the research team. So we're not seen as two separate people who are trying to monitor the study, because our previous experience have been, people will not be very honest with us if they did think that we were monitoring another study. And so we had focus group discussions with the participants, and these focus group discussions happened after the challenge study, after they had been in the facility for a week or thereabout. So they had already had the experience of what does it mean to participate in the study. Observations were going throughout, right, at community engagement, information giving, and consent processes. And also the researchers did a self-administered questionnaire that was taking understanding of participants about the study before they enrolled them. What I'm going to present is more the findings from the qualitative data, the focus group discussions, in-depth interviews, and the observations. I'll not talk about all the main themes that came out. This is from mathematical analysis of the data that we got. But I'll talk about the highlighted ones. In terms of information and consent processes, what came out is all those who we interviewed were aware that they were taking part in a research study. And they had a general understanding of the aim of that study, that it aims to develop a vaccine. How soon or how quickly that vaccine will be developed was not always obvious. So they thought probably the vaccine will be sooner than how researchers are thinking about it. They also understood that they had been injected with malaria parasites. That was clear, and as a result, they are likely to get malaria. They also knew that malaria was curable from their past experiences of having had malaria and treated and cured, plus the presence of the clinical staff who were at the facility throughout 24 hours and who would provide care of any ailment that they had. And that was and they did say that if it had been any other condition that was not curable, for example, they talked about HIV, they were very clear they would not have participated in the study. So this is one participant who said, I was injected with malaria, I haven't been sick for 4 years, and I don't know how serious the condition will be. However, I just volunteered, and it's because we spent the night with them, these are the nurses, day and night. I know that if my head starts to pain, I'll go to him or her for them to see how they can help me. And I think there was a very strong sense that they are getting very good high-quality health care. They, however, felt that there was quite a good number of blood volumes or blood draws done on them, and they were not always very clear how much that was at the time of giving consent. And so they suggested to the study team that next time they should use visual aid to explain. And this has already been incorporated in the next group. Risks associated with study. We started exploring what do they think were the risks that were associated with the study, because often challenge studies, especially around malaria, are described as low risk. and especially in malaria endemic area, where anyway people are exposed to malaria and are likely to get malaria. And low risk means where the magnitude and probability of risk does not exceed what participants would experience in their daily life or during routine examinations. It was discussed, the level of risk were discussed widely throughout all the engagement processes, but also in the multiple stages of information giving. And the consent form was very detailed on the types of risks, the different types of risks that participants are likely to be exposed to, or they might get, the probabilities of they might get, including potential to get sick from malaria parasites that are injected into their body, and also potential for infection of the site where injections are being done or where blood draws are being done. And we also go further to describe the pain that they might experience when blood draws, are being done. So it was very detailed, the consent form. But also in terms of what it involved, also inconveniences of being in the study were described, and participants seemed to be aware of this, including the inpatient stay. They were fully aware that they will be treated if they did get ill, and they said categorically, I've already said that if they did get, if the challenge was around any other condition, then they would not have participated. I would have already said that. So having said that, therefore, what was the motivation for them to participate? What came out across all was the healthcare benefits that they were receiving. And these were talked about during the screening process itself. The tests that were done would ideally have been too expensive for an individual to even undertake. And also the presence of 24-hour clinical team taking care of all the healthcare, any ailment that they had was highly appreciated. And also healthcare after discharge, after they have been in stay, during all the follow-ups, they were going to be treated for any malaria-related illnesses, and they seem to appreciate that a lot. Some did talk about altruistic reasons. That didn't come out spontaneously, but they did talk about the fact that their participation is good in terms of promoting science, in terms of contributing to vaccine development. But they often talked about this and balanced it with the level of compensation. And they did say that if they were not being compensated, it was very possible that they would not have participated in the study. One said the vaccine is important, but if you had not been told that you are coming to look at the vaccine, and you had been told, for example, that this was free of charge, there's nothing you'll get, there would be no people willing to join. Also, others said that by participating in this kind of study, they felt that they were supporting the work of the program, and they highly valued the role that the program plays in the community. Again, I've said already compensation was a very big motivating factor. And they knew that the compensation was not really the payment for participation. Rather, it was compensation for lost times and the high levels of inconveniences of being in stay for so long. And they seemed to do what we called a cost-benefit analysis, where they would be weighing out how much would they have earned if they were at their own homes doing their own casual labor versus what they were gaining or what they were earning by participating in the study. And like one of them said, I normally sell clothes. I did my calculations. Per day, if I go to the market, I sometimes make more than 300 Kenya shillings. That's around £30 US dollars. But sometimes, like now, there's no money. You make like $10. Sometimes you make like less than $8. So I thought these $20, I've just kind of translating shillings into dollars. Every day are better. If I manage to stay for these 24 days, I'll have gotten a lot more money than going to the market. So I decided to come here. And quite a good number of them seemed to say that was a very huge motivating factor. Obviously, in addition to that, we also wanted to know how they felt being in residence for that period of time. And most of them understood the importance of being in residence, that it was close monitoring, there was ease of undertaking study procedures. It also helped them avoid getting malaria because they would be, they were sleeping under mosquito nets, there was close monitoring, there were indoor spraying, so it was very nicely controlled so they don't get malaria. They were overall pleased, but of course they also had complaints, and most of them were, about food, the quality of food, about water in the rooms, sometimes about relationships. What is striking is that nothing much was about the study itself. It was more of the practical, logistical things that needed to be taken care of. But I don't think we need to undervalue that, because that has got huge implications on how they saw themselves participating to this study. It was also interesting that compared to men, women were more positive about staying in the residence. They perceived being in the residence as an opportunity to rest and relax, while men felt restricted. Some of them said they had gone on holiday. So there's a lot. This is just a small portion of the data that I've presented, but I think there are some areas that start to emerge, and I'm just flagging them here, not because we have the answers, but because I think it is very helpful if we can debate about this. And some of them, obviously, are about some of the intended consequences that might emerge by having these kind of studies in these kind of settings. And some of these could be issues about compensation. How do we make sure that we compensate appropriately? What do we need to consider when we are thinking about compensation? And how do we kind of safeguard ourselves against having what we call professional research participants? And I don't know whether that is a good thing or a bad thing. I'm just posting it out there, because this could very well be an income-generating activities for people. Is that a good thing? Is it a bad thing? Should we worry about that? Maybe, maybe not. But also what we noticed is this tendency of jealousies among us, those who are participating in the studies and those who are not. And this emerged, those who were screened and didn't get into the studies, and those who were screened and got into the studies. There was always an issue of, why was I not selected? Why did I not end up gaining this? The extent to which this has been experienced is what we are exploring in our next phase. It emerged in these groups, but this was a group that had all participated. So we don't know about those who did not participate. That's something we want to follow on a little bit further. It also emerged that there were differences within families. There were people who said, I really didn't say at home where I was going to, because if I'd told them, they would not, and this was for young people, but also for married couples. If I'd told my spouse that I was going off to participate in research, they will probably not want me to go off for so many days. But I'll go and deal with that situation when I go back. I'll go back with a nice sum of money. So that is going to help my family. And they felt they didn't need to tell people what they were going off to do. Not all of them, but those did emerge in a few cases. And then there's this, what we call fair benefits framework that has been used a lot for many of the research in developing countries. And we are wondering whether to still use that framework, or whether it's still very applicable. What other types of benefits do we need to consider when challenge studies are happening? And especially knowing that it's likely to create some kind of imbalance between those who participate in research and those who don't. Are there things that researchers need to consider? Is fair benefits framework still very applicable in these kinds of studies? What do we need to consider? Some of the questions that I did pose was also about risk of being involved in these kinds of studies. Are they really low risk, as suggested in the papers, and as people often tend to think about them? Is there something that we need to take into account? I know somebody raised the issue of intentionally infecting people. How is that framed within the framework of risks? It might not be seen as a risk. Is it a harm? How do we take account of that? So those are questions that I hope we'll be able to debate and get some guidance. Thank you. I just wanted to acknowledge the Malaria Challenge Study team and all the participants and the team that helped this work to move forward. Thank you.
Thank you, Dorcas. That was fantastic. So, any points of clarification for Dorcas? We'll get to the discussion later.
Thank you so much for presenting that. I just have one question especially about risk. You've talked about, most of the risk you've talked about is on the study itself and the outcome. What about other aspects of risk, especially cultural risk? You know, I don't know whether some of your participants were married, and especially coming from an African culture. We know that if a woman goes out to, a married woman spends her night somewhere else without the consent of the man, it will be an issue. So when you are writing your consent, did you also go to an extent of maybe getting consent from the spouse? Because there could be a risk of family breakup after that. Are you also doing follow-up after that to see whether these families are still stable?
Thank you. I think that's part of the dilemma. Should we consent spouses as well? I think that will be interfering a lot with relationships that we might. If you can imagine, you had 30 couples, all of them participating. The nature of relationship between couples is so different. So do you really want to get into that? I think not. But what we did, and at every stage, right from community engagement to consent processes, is give people time to go back and discuss. Community engagement wasn't just with the participants, but with the general population. So where we were recruiting from, we would go there and hold community meetings and discuss about the study. And so if you knew your spouse was likely not to like you participating, you had many opportunities in which you can go back and say, look, you know what, this is happening, I don't know. I don't know, I just don't think I can stretch consent process to consenting spouses because again, that undermines the individual autonomy. And then what might you end up doing? We've written some studies about issues on what might happen when one is blamed for certain things in the household because of participating in studies. And we know that can be a very difficult situation.
Thank you. I had wanted to ask this one, the first speaker, but it's about compensation and reimbursement. I think what you have been referring to basically would qualify for reimbursement. Why am I saying this? What if you had serious adverse events in the process? What would that one be? Like somebody dies or somebody is maimed by the disease you're introducing. So how did you deal with that one? Because like in the African setting, most countries, we don't have medical insurance. So people are not insured in the event that somebody dies. How did you handle that one at the review process? And what precautions did you have? Or what would you do? And the final question, was your consent informed? Maybe yes. Was it voluntary? That one is for you to answer.
I think you raised a very good question of terminology of compensation versus payment. I do agree that we've used them quite interchangeably. Probably we need to be more careful how we use them. I know in our guidelines we've used them quite. We've talked about reimbursement as actual costs that have been spent, and we've talked about compensation for any other inconveniences. In the study, that's how we describe them, but obviously this is terminologies and we can discuss. In terms of what happens if somebody gets sick, if somebody adverse events did happen, that was very clearly stated in the protocol. There was full, there was full coverage, insurance. There was a very careful, it's a very thoroughly careful protocol. I'm not a scientist per se. This is not my field. I'm more of a social scientist, but I know there were very clearly stated procedures of what should happen, not only for that, but anyone who got sick, not just even to the point of death. So that was very clearly spelled out. Was this voluntary? I think there can be a lot of discussions of what voluntary means. Is it the first time that we are seeing compensations or even payments being considered as important? I think it's not the first study. If you look at a lot of studies in developed countries, phase 1 trials and whatever, you find their rates of compensation are so much higher, and people do participate because of that. And we are very aware that if you don't offer appropriate levels of compensation, people will not participate. So they said very clearly, if you're not giving me anything, I will not participate. Does that affect voluntariness? I think that is a very nice theoretical discussion. There are some papers that have looked at what does voluntariness mean. And I'm happy to kind of forward some papers around. But yeah,